To this Think Global session, whether you're here with us or here in Trent or joining us online. We are delighted to have you all be with us here today. My name is Joseph Kipoech, the program coordinator in charge of international partnership here at DGHI. And I also work partly with the Moi University, Duke University collaboration team looking at malaria in Kenya. A few logistics, just to keep you informed. In this session, we are going to record this particular webinar, and it will be posted publicly, so your questions and comments may be seen by others. And we'll have time for Q&A. And if here, please feel free to raise your hand. And if online, we'll have the Q&A tab available on the Zoom platform. So feel free to ask or write there at the end of the session. So, quick introduction. This is a session titled Uncharted Territory, Confronting a New Malaria Threat in Kenya's Turkana region. And in this session, the panelists will explore how malaria epidemiology in Turkana is changing and how community-centered interventions are responding. Turkana is often on the front line of climate change. This is malaria not as an occasional crisis, but a persistent challenge shaped by mobility, drought, and limited infrastructure. We'll highlight how communities, county leaders, and research partners are working together to translate evidence into action in a region long overlooked in malaria control. I'm delighted to introduce to you today's panelists. We'll start with Professor Wendy Omiera. As you all know her, and those who haven't met her, Professor Wendy Omiera is the Deputy Director at the Duke Global Health Institute here, and the Professor of Medicine, Global Health, and Population Sciences at Duke University. Her work integrates rigorous epidemiology with implementation science to address persistent malaria challenges in real-world setting across East Africa. We also are delighted to have Professor Diana Menya. Diana Menya is a professor of public health at Moi University, School of Public Health, a medical doctor by training, and a founding member of the College of Health Sciences and the Department of Epidemiology at the Moi University College of Health Sciences. Her work bridges clinical medicine, epidemiology, environmental health, and global health research collaboration, including long-standing work with Professor Wendy Omiera on malaria diagnostic, treatment, seeking behavior, and health system strengthening in Kenya. We are also delighted to have Dr. Gilchrist Lokoel, who is an alumnus of Moi University School of Medicine and currently serves as Turkana County first Chief Officer of Medical Services. He's a medical doctor by training and a public health leader who has strengthened healthcare delivery across Turkana, leading outbreak responses, expanding hospital infrastructure, improving maternal health and child health outcomes, and championing innovative and community-based intervention. Let's welcome this particular team, wonderful team of panelists who will be taking us through this presentation. We'll begin with Dr. Gilchrist Lokoel, then we'll open the floor for other panelists to continue, and then we'll wrap this up with final thoughts. And so let's dive in. Welcome. All right. Go ahead.
Thank you very much, Mr. Koech. Good evening, everyone.
Sorry.
My name is Gilchrist Lokoel, as Mr. Koech has introduced. I serve as the Chief Officer for Medical Services in the County Government of Turkana. And the photo you are seeing right in front of you is a typical photo of Turkana that shows you the nature of livelihood of the Turkana people, which is 60% pastoralists, 20% agro-pastoralists. Incidentally, we have the largest saline lake in the entire world called Lake Turkana. So 12% of the population, they are also fishermen. And a paltry 8% are involved in aspects to do with, casual laborers, formal employed, etc. So Turkana County is one of the hottest regions in Kenya, with the temperatures fluctuating between 34 to 39 degrees. On your left, you can see the effects of climate change and the ones who are bearing the true brunt. Women carrying water on the head with a very dry area with high temperatures to boot. So effects of climate change has brought prolonged, persistent and frequent droughts, drying of vegetation, increased temperatures that has affected our health, floods whenever the drought season ends, and therefore you can see the acacia trees all over the place. Then on the right of that photo, you can see also the Turkana hut. That is the typical hut that Turkanas have because of the migratory nature of our population. We cannot put permanent structures. So that hut is made of tree branches and twigs, and it is very cool inside. Incidentally, the population does not sleep inside that hut. Most of the sleeping is done outside the hut because the men has to take care of animals outside, and women have to be busy watering the animals and looking for wild fruits outside there. The Turkana later on, as you can get to see, it's bordering 3 international boundaries. If you look up north, that is the map of Kenya. Turkana is where that square rectangle has shown. It is bordering South Sudan on the northwest, Ethiopia on the northern side, and it's bordering Uganda on the western side. So geopolitically, it is strategically located. And it is the largest county in the entire of Kenya, occupying 13.5% of landmass. Incidentally, it's also the poorest, with 83% of the entire population being ultra poor. Healthcare delivery initially was as a result of missionaries, faith-based organization, more importantly, Diocese of Lodwar. You can see that is a health post. I have 307 health facilities, and this is just one among many others that are scattered along the migratory route and the settled population of the entire area. For those of you who don't know Turkana also, Turkana is a bedrock of origin of humanity. The oldest fossil in Kenya that was discovered, carbon dated to 1.6 million years ago, was actually discovered in Turkana, which means Turkana is actually the origin of mankind. And today, we are actually getting into uncharted territory where humanity credo is under threat from effects of climate change. And therefore, I want to welcome you all to this discussion, and over to our next presenter. Thank you.
I'll give a brief, I'll begin with a brief introduction to malaria in Turkana to help you understand how we began conducting research there. So go back, please, one slide.
Yeah.
So this satellite image of the upper part of East Africa shows that the northwestern side is extremely arid. You can also see that the terrain across northern Kenya looks more like Somalia and its neighbors along the Horn of Africa. It is quite dissimilar to its immediate neighbors, Uganda to the west, Ethiopia to the south, and South Sudan also to the north. The region receives about 12 to 20 centimeters of rainfall per year, sometimes much less during drought years. That is about 5 to 8 inches of rain for those of you who don't use the metric system of measurement. So rain in Turkana is becoming more erratic, like in many parts of East Africa, both in quantity and in timing. So due to the harsh conditions, these areas of Kenya are also very sparsely populated. Turkana, as Gilchrist has said, is the largest county in Kenya in terms of landmass, approximately 77,000 square kilometers. That is about 30 square miles, with a population of 1.1 million. It is nearly the same size as South Carolina, but South Carolina has nearly 5.5 million people. Most families in Turkana practice nomadic or some semi-nomadic pastoralism. Next slide. The malaria risk in Turkana has long thought to be nearly absent. This malaria risk map produced by Malaria at Risk Project for 2014, you can see that most of Kenya, except for some areas around Lake Victoria and the coastal region, is predicted to have very low Plasmodium falciparum malaria, and Turkana is no exception. At that time, it was expected to have fewer than 0.1 cases per 1,000 people per year. Next slide. Because Turkana is very arid, sparsely populated, and thought to have very low predicted incidence, there was no investment in malaria control measures. The map on the right shows the distribution of mosquito nets. That is on the right. Yes, shows the distribution of mosquito nets up to 2023. And you can see that the government did not distribute any nets in Turkana. Anti-malarial medicines have been available in the facilities, but very few, if any, preventive interventions had been implemented. So in 2017, my colleague Wendy got a call from an entomologist colleague who was working in Turkana. He informed her that they were seeing many unusual species of Anopheles mosquitoes and that she should go and have a look. So we had heard about sporadic news stories about malaria outbreaks in Turkana, but thought that these were rare isolated events. But still, we decided to visit Turkana. But before we went there, we visited the National Malaria Control Program, which is headquartered in Nairobi, as we always do before we start any new project. They told us that there was no malaria in Turkana, basically dismissing the notion. So we went to Turkana anyway and met the Turkana health team. In the team, we met some Moi University graduates like Dr. Gilchrist here, who has spoken just before. He made community entry into Turkana very easy for us and got very many doors open for us. So Dr. Gilchrist and team told us that they're on the ground and that Turkana and that malaria is a major problem there and always has been there. Next slide. So given the contrasting perspectives, we decided it was important to conduct research and try to understand the situation and quantify the malaria problem in Turkana. So initially, we had 4 research questions. Next slide. So we asked, is malaria endemic in Turkana, or does it occur in occasional outbreaks and isolated upsurges? Secondly, we asked ourselves whether transmission might be ignited and sustained by regular importation of parasites into Turkana from surrounding areas. We also wondered whether seasonal migration of families in search of pasture and water could affect transmission. And finally, if we did find malaria there, which vectors were responsible for transmission and where were they breeding? So I'm going to go through the answers to these questions briefly. Next slide. So we conducted reactive case detection, selecting 3 urban facilities in Lodwar, which is the capital of Turkana, and 3 rural sites to the east. Individuals reporting to health facilities who tested positive for malaria were invited to enroll in the study and enroll their households. Community health workers then visited the households and enrolled each member present. Next slide. We found malaria cases in health facilities year-round, with seasonal peaks, as you can see in this slide. And of the asymptomatic, next slide. So we found that malaria prevalence across the study area ranged from 10 up to 60%. Asymptomatic cases were present throughout the year including even in the dry seasons. Next slide. So next, we looked at travelers. We set up surveillance at the bus station where people gather from all over Western Kenya to make the road trip to Lodwar. The second surveillance site was at Eldoret Airport, where people fly to Lodwar from Eldoret and perhaps even beyond Eldoret. Next slide. We found that travelers from all these other malaria endemic areas of Kenya had relatively few infections compared to the community members. Only about 6% of the travelers had parasites. Next. So we sequenced parasites. Go back one slide. Yes. We sequenced parasites from the traveler infections and leveraged parasite genetic signatures to determine whether parasites were imported and then ignited transmission chains. You can see from this transmission network on the left that we could identify parasites that had been brought in, that had been introduced by travelers, which then trigger small chains of events, and you can see them in the colored chains. However, the vast majority of transmission, represented by the gray dots, occurred within the community, independent of travel. And even if you stopped all parasite importation, it would have a negligible effect on transmission. Next slide. So local transmission is high, and we showed this in the previous work that I have described, and it is not sustained by importation from other parts of East Africa. But is it affected by a much more prevalent form of travel in Turkana, that is seasonal migration? This type of migration could affect malaria transmission because herders are congregating around water sources with large numbers of animals, which are excellent mosquito bait. They camp near water and sleep outside on the ground. So this could really be a perfect environment for increased transmission. To understand this, we recruited semi-nomadic families in which some members leave the family group, they leave the village, to accompany the animals in search of pasture for extended periods of time. At the same time, the rest of the family remains behind in the villages. So we recruited 200 such families and measured infection in all household members before they left with the animals and upon their return. We also asked those traveling to carry GPS trackers so we could better understand where they go and for how long. Next slide. So this slide shows the migration route for two individuals. Time is on the x-axis and on the y-axis is distance. The red dots, or pinkish or orangish dots, are daytime locations, and the green dots are where they slept. You can see that these two individuals have different patterns of movement. The person on the left traveled long distances and then stayed in the same place for weeks at a time. He then moves to a different location and stays for weeks again, and so on. The second person on the right traveled continuously and slept where he spent the day. So he was always on the move and slept where nighttime found him. At the end of the migration period, when they returned to their villages, we found that travelers had more than 2 times the odds of acquiring an infection during the travel season than those who stayed behind. So this means 2 things. First, travelers are exposed to malaria while away and bring parasites back home. Secondly, seasonal mixing of populations could be increasing overall parasite genetic diversity. Next slide. So, malaria is a man-made disease. Vectors exploit the ways that humans collect, use, and store water, like everywhere else. This slide shows some opportunities that vectors are exploiting. On the far left is water panning pits. These are actually dug on dry river beds as the community tries to fetch water after the rivers have gone dry. On the right is irrigation, man-made irrigation canals, which are dug out of seasonal rivers. And in urban areas, we have a, can I see the next slide, please? Yes, in urban areas, we have these open cisterns, which also are breeding sites for malaria. Next slide. So we decided to have a look at the vectors, and we set up a year-long surveillance of adult mosquitoes in urban and in rural areas. We found that the vector population is not very similar to what we find in the southern part of Kenya, where we also work. We found a lot of Anopheles arabiensis, which are well known to us from our work that we've been doing around where we are here in Western Kenya. They also bite humans and animals, and a few of the females we caught were infected with parasites. We also found a lot of Anopheles colusi, which is normally found in West Africa and in the Sahelian region. So we were surprised to find it in Turkana. Nearly 3 times as many colusi were infected with malaria than any other species. So these guys seems to me are really very busy biting people, biting us up there in Turkana. Finally, we found a few Anopheles stevensi. Next. Yeah, there we are, that new guy. So this is an invasive malaria vector species that we identified for the first time in Kenya in late 2022. It is endemic to Asia and has spread through the Horn of Africa, causing devastating outbreaks in Djibouti, in Ethiopia, in South Sudan, along the way to where we are. Next slide. The invasion of Anopheles stevensi, next. Let me see the next slide. Just go back one. There, that's fine. Forward, please. One. The invasion of Anopheles stevensi into sub-Saharan Africa has been designated by the World Health Organization to be a major threat to malaria control and could put an additional 55 million people at risk of malaria. Next. We now know, at this time, we know that stevensi is present across the entire arid stretch from northern Kenya, as represented by the red dots you can see over here. The whole of northern Kenya, stevensi has been identified. Next. Unfortunately, stevensi is a very competent vector for both P. falciparum and P. vivax. In fact, it is the one that brought the first cases of P. vivax to Djibouti, which was on the brink of malaria elimination before this stevensi arrived. We do not know for sure if it is related to stevensi, but we ourselves confirmed the presence of P. vivax in Turkana. So I'm going to stop here and have Wendy continue.
Thanks so much, Gilchrist and Diana. So this is where we are now. This is the malaria risk map from the World Malaria Report in 2024. And these changes in the classification of risk in Turkana are directly as a result of the work that we did with the Turkana County Health Team. And so I'm also happy to say that Turkana County Health Team was able to use this information to advocate with the National Malaria Control Program. And in October 2024, they distributed the first bed nets in Turkana. So we're really delighted that we were able to provide this evidence, that they were able to advocate for policy change and for nets in Turkana. But at the same time, we knew that nets were going to be challenging for Turkana people to use. We were hoping that they would get them, but challenging for them to use. So on the right, you can see a woman who is erecting her new bed net on a sleeping space that's outside on the ground. And so every night she has to put it up on these sticks that she's anchored into the ground. So it's not that easy to incorporate nets into their daily lives. Next slide. Okay. So these are Diana has shared some things that we learned when we partnered with program implementers and policymakers and communities to really tackle their most pressing questions. But we couldn't just measure things and then pat ourselves on the back and leave it the way that we found it. And we start with evidence and then we start to innovate. So even before the NET campaign was a twinkle in the NMCP's eye, we started brainstorming what kinds of prevention tools could be effective in this context, and especially given the really high morbidity and mortality amongst very young children. Next slide, please. So we focused on drug-based prevention strategies. Turkana, as we've already reviewed, is very dry. Malaria transmission is highly seasonal, and even the types of vectors that we have are a lot more similar to the Sahel than to the southern part of Kenya and the rest of East Africa. So we adopted an approach that's been used successfully in more than a dozen countries in West Africa called seasonal malaria chemoprevention. And this involves giving a course of long-acting anti-malarials to kids, usually kids under 5, once a month for the entire transmission season. And so you give this drug, it's a combination of sulfadoxine and pyrimethamine. We decided to give it in 5 monthly cycles from June to October to protect kids during the transmission season. And before we embarked on this adventure of trying to find these nomadic families and these kids and give them drugs every month on a 28-day schedule, we worked with communities to really understand how we could execute this kind of intervention, given the mobility and the very remote location of the families. And we partnered with the county and with Catholic Relief Services to design a delivery strategy that can meet the needs of the community. Next slide. So the county team with CRS led the implementation of this intervention, and the Moi collaboration focused on the evaluation. So in order to measure the impact, we enrolled a cohort of 200 kids in the intervention area and 200 kids in the adjacent non-intervention area. And we trained community health workers to do active case detection. Next slide. And they visited every home of these 400 kids once a week, and anytime they identified a malaria-like illness, they would do an RDT and collect red blood spots. Next. Sorry about the background noise. I'm stuck in the airport because there was a airport workers strike today, so I can't help it. Okay, so this is what we found. We had about 150 malaria episodes in 5 months in the non-intervention area in Turkana North. Next slide. And only about 50 in Turkana Central, that's the intervention area. Next. And this gave us a reduction of about 71% in incidence of malaria cases in these kids. So I really just want to highlight that this was measured on real-world operational conditions. And as a result, the coverage was imperfect. There was not 100% coverage. This was not a clinical trial style impact evaluation. And we also recorded that about 3/4 of the malaria episodes in the intervention cohort were in children who had incomplete SNC, so they had missed a couple of cycles of SNC. So all in all, this was a really exciting outcome. And we were really pleased with this. Next slide. So at the same time, in 2024, when we were doing the first ever SMC program in Kenya, in Turkana, Turkana was having its worst malaria season ever on record, and this was triggered by catastrophic flooding early in the season. And by September 2024, the county had recorded 400,000 cases of malaria in the local health information system in just that 1 month of September. And remember that there are only about 1.2 million people in the county. So it was really a staggering malaria season. So this pictures that I've put on this slide, this is the Kakuma refugee camp, and it's the third largest refugee camp in the world. It's home to about 350,000 people, and it's plunked down here right in the middle of the desert. And so that same month of September, when we were in Turkana Central protecting 40,000 kids from malaria, 100 kids died in 1 month, in that same month, in the refugee camp hospital. Next slide. So I'm really pleased to report that with the advocacy of Turkana County Health Team and Catholic Relief Services, we partnered with IRC, UNHCR, and Red Cross, and we were able to distribute SMC in the refugee camp as well as in the Turkana Central communities. So in 2025, we protected over 80,000 kids in those two communities. So I'm going to hand it back over to Gilchrist to bring us around full circle. Next slide.
Thank you, Prof. Wendy. I want to bring to your attention that Turkana currently is experiencing what I call vagaries and vulnerabilities of climate change. Over time, it has affected all facets of our life as a Turkana people, and it has caused a lot of things. One of them is what you saw in the first photo, water scarcity, where the ones who bear that brunt are women and children. It has also caused food insecurity. Food insecurity is what has given us high and prevalent and persistent levels of malnutrition of more than 30% against WHO recommendation of less than 15%. We have lost the biodiversity of our environment, and a lot of our environment has been biodegraded by Prosopis juliflora, and also the refugee population that we are hosting, about 400,000 of them. It has also caused effects of degradation of our infrastructure and increased disease burden, including malaria. Education essentially came to Turkana in the last quarter of the last century. But before then, we used to document our years through what we call an ethno-ecological calendar. The ethno-ecological calendar is whereby we named years of drought, of floods, of our experiences based on the vivid reminder of how that drought or that flood made us feel. So we documented them for the last 100 years. And to be honest with you, if you look next, if you look at what is indicated in terms of next slide, please. If you look at the naming of these droughts, Apetakale. Apetakale is a Turkana word, no, just before that. Apetakale is a Turkana word for meaning the river had burst its bank and caused flood all over the area. We experienced that in 1924. And according to the people, they say that God had lost the padlock to heavens, and therefore the rain just came without any measure or regulation. So that was 1924. Ekuakoit is a Turkana word meaning white bones. Immediately after the floods, the following year, there was huge drought that killed a lot of animals, so much so that the carcasses of the animals were strewn all over the landscape and making it look white. That's what is called Ekuakoit. And it was in 1925. Which was, and yet Apetakale was 1924. So you transition from a year of plenty to a year of drought. Then in 1933 is what we call Arengedome. Again, a severe drought where we started feasting on wild fruits for survival. The one that is vivid to everyone, most of them they are still alive, is Lotira. Lotira means drought that is standing and not going away. And that was in 1952. So when you say I was born in the year of Lotira, we know that is the bad drought of 1952, and that is how Turkanas documented effects of climate change that happened during that time. Lotira never went. It gave way to what is called Locolite in 1953. And so the two bad years fused, and they portended loss of massive number of livestock for the Turkana people. The next one is epetapus, which was a wet season in 1958. Epetapus just means there was a green lushy vegetation all over the Turkana people. Now, motor is an interesting one. It's a bad year that occurred in 1960, and it's a Turkana word meaning an emaciated cachexic animal, because even wild animals, there was no vegetation for them to feed, and they look like a cat that is about to pounce on somebody. So you become so thin and so cachexic and so frail until your spinal cord bends. So we call it the year of Namotor. Lopier is the year where I was born, 1980. It's one of the worst years because almost 90% of animals were lost. And therefore, people became so vulnerable to the point that they were eating, hides of animals so that they can be able to survive as they wait for the dry season. So what you are seeing here is the way the Turkanas immortalize these years. The year of plenty will always give back to the year of deficiency or scarcity. But the frequency and the longevity of these years is increased after the year 2000. For the last 20 years, hardly does any year pass before this experience is felt. But matters are compounded by oil exploration. Oil was discovered in the southern belt of Lokicher. And tallow oil has handed over that oil prospection and drilling out of the soil to Gulf Energy. Already when tallow oil was bringing the initial oil out, cancer cases were reported, especially leukemia and liver cancer and death of animals around that area. So the future actually looks again terrible and bleak for us. The second thing is the refugee population. All our neighbors, there is fighting in southern of Ethiopia, there is intense fighting in South Sudan. So all those refugees are coming, and now we are hosting the third largest refugees. When they come with cholera, they come with measles, they come with even some diseases that the world was eliminating, like Drunkunculus medinensis. It's called drunkunculiasis, which is guinea worm. So we thank God as Kenya, we managed to eradicate it like 6-7 years ago. But the refugees, they are a big challenge to us, and they are threatening the fragile health ecosystem that we are already experiencing. Locust invasion. So it appears there is a conspiracy between nature and everything else just to ensure that the situations are getting very tough. 3 years ago, we had a huge locust invasion whereby vegetation of the entire Turkana was swept away. So it means that it is forcing us to think resilience. It's forcing us to think adaptation to all these massive climate changes. And now, new issues are emerging. Malaria, that Professor Wendy and Professor Diana Menya have mentioned. We never used to be categorized as a malaria zone. When I met them in the year 2018, I told them that from my clinical practice, I saw a lot of malaria cases, and even under 5 deaths. But my national malaria control program was saying there is no malaria. I want to sincerely thank the two soldiers of science, one from Duke University, Professor Wendy, and Professor Diana Menya, for coming in to us and ensuring that we developed enough evidence to this. You see the effects of climate change in that photo. The left one is like Turkana bursting its bank. It has displaced the 12% population that are living on that end. And also this thing is now creating as a breeding ground for mosquitoes. And moreover, crocodile attacks, things that we never used to see, they are now attacking people. And that is why when I spoke with Professor Wendy, I said, indeed, Turkana is a laboratory of disaster. Everything that may have gone wrong, it has gone wrong in Turkana. And over and above malaria, trachoma, which is caused by Chlamydia trachomatis, which causes preventable blindness, is now rife in Turkana because of effects of climate change. Malnutrition levels have skyrocketed to global acute malnutrition of between 26% to 36%. Non-communicable diseases, because we've lost animals and people are now coming to towns. So urbanization is taking effect. Diseases like diabetes, hypertension, cancer that we never used to know. When Professor Diana Menya trained me in Moi University and I came here in 2008, there was no one single case in my ward of diabetes, hypertension, or cancer. Right now, those non-communicable diseases, they're actually rife. And then things like snake bites, they are now becoming major issues. Sexual violence, the highway has been fixed by World Bank. So road traffic accidents, now other issues, health events are emerging. In my view, this collaboration of scientific and academic partnership has actually helped me as a decision maker to plan programs that I feel are going to be helpful to the people. And finally, I form the opinion that together with the rest of the people of Turkana, we are staring into an emptiness of uncertainty. And it is causing us a lot of anxiety as a people. We are at the cusp of either making it and adapting to climate change, or climate change literally dealing us a big blow by exterminating most of us. So we are therefore extending our hand to the global health community so that we can be able to hold our hands, so that we can partner together and develop health system resilient interventions that can be able to save the people. Otherwise, I want to thank all the Turkana County government, Moi University, CRS, the National Ministry of Health, Duke Global Health, and all the people that are mentioned there, including my brother Mike Pell. Otherwise, thank you very much.
Yeah, thank you very much. We have we done well in terms of time? I think yes. So probably we'll open up for questions and answers. Remember that we have a Q&A for those who are joining online. Please go ahead and use the Q&A tab. And for those who are in the room, feel free to raise your hand. But I'll go fast and ask a few questions to probably Gilchrist and Diana. And this is, describe how you engage communities in your work and the impact of that engagement on the outcomes and the partnership in general. You can go ahead, either Diana or Gilchrist. And then my other question will go to Wendy. Is the presence of the Sahelian vector challenging the classic East African malaria assumption? And are our current vector control tools fit for the ecology? I think those two questions, you can go ahead and answer those. And then we can open up for anyone else who has questions.
So before Prof. Menya, Mr. Koech, over time, we have invested in engaging communities because they are the end users of the healthcare system that we provide. We've developed systems like community health services, whereby members of community are trained to act as a link between health care workers who sit in health facilities and the community. We've organized community dialogue days to reach out to communities. So we've built a bank of trust over time with communities, both through the national government structures and the county government structures. So much so that in the Moi University and Duke University, in quotes, soldiers of science came calling, we were able to quickly activate this mechanism after we were satisfied as a leadership of health that the intervention and the research was actually something that we needed. Because you'll agree with me, malaria was the elephant in the room. People were not receiving mosquito nets. People were not receiving any novel, things that can be able to change the way they operate. And I'm glad enough that with the introduction of SMC and with generation of evidence that we created, it led for the first time since the world was created to the national government bringing 1.4 million nets, long-lasting insecticide-treated mosquito nets to Turkana, which has given a lot of impact because it has now reduced my expenditure in terms of treating people who have severe malaria. Thank you.
Thank you.
Diana, you're on mute.
Oh.
Okay. So in working with people in Turkana and indeed any other community that we've worked in, but let me focus on Turkana. The first thing that we have as Moi Duke collaboration is respect for the people. That's thing number one, is respect for the people, and also to recognize that people actually know what problems they have, and they know what solutions should be implemented to solve their problems. They just need a little bit of a push from us. So we don't go to the communities oh, here we are. What do you call ourselves? So here we are. We are from the ivory towers of academia and research institution, and we are here to help you. We are here to solve your problems. No, we don't go that way. We go there and through the proper community entry channels. And for Turkana, like I said before, Gilchrist made it very easy for us and opened all the doors for us. Because to get to the village, to get to finally interview the person that you interview, there are so many steps that you have to go through. You have to go through the chiefs, the assistant chiefs, the village elders. You have to go through crowd leaders. You have to go through maybe the tree of men and so on and so forth. And all these are gatekeepers that if you don't go properly through them, you will not interview that person that you wanted to interview. So us, with humility and respect, we approach the community entry process and we take it very, very seriously. And we don't skip any part of it. And we allow the community, the health leadership led by Gilchrist, to guide us as to how we get to the communities. And over time, since 2018, the Turkana community has built trust in us. They have seen that we are accepted by their leadership. So then they also accept us. The other thing also we do, and we did this in our SMC evaluation work, is that to get to the population, you get to them through somebody that is trusted. Like, for example, the community health promoters. These are the ones who distributed SMC to the household level. The community trusts them because they live with the community, they move with the community. And so then we asked the community, before we started doing this evaluation work, we did baseline study to understand the Turkana people, to understand what structures they have, to understand how they do things, and to understand what kind of delivery methods they wanted to receive SMC. And they told us, and we respected this, and this is what we did. So that is our approach to community work and the successes that we have had in the community in Turkana. Over.
Thank you very much. Over to you, Professor Wendy.
Yeah, thanks. So regarding the vectors that we have there and vector control measures, it is still important that Turkana was able to get nets because they will provide personal protection for the people who are able to use them consistently. The fact that a lot of the vectors that we found in Turkana equally bite humans and animals suggests that the vector population may not crash with the use of bed nets the way that the vector population crashed in places where you have mostly anthropophilic vectors. But there are opportunities for other vector control measures. So one option that we are going to test out, and we're starting a trial soon in collaboration with Kemry Wellcome Trust, is to treat animals with a medication that kills the mosquitoes when the mosquitoes bite them. So because we have so many vectors that like to feed on livestock, this kind of One Health approach where we use these big mosquito bait cattle and goats and treat them with an insecticide that can kill the mosquitoes could be a promising option. And so we're going to test that out. But we will have to be creative and innovative because I think a lot of the ways that we've approached vector control, I mean, you've seen the housing construction, right? You can't do indoor residual spraying because there's really no indoors and outdoors. So we're going to have to be innovative and creative and think about how we're going to target the vector population.
Thank you. Yes, we'll take a question. Welcome, Chris.
Well, first of all, thank you all and congratulations. It's so impressive what you've been able to achieve. I wonder if you could reflect, I think one of the things about your work in Turkana and the collaboration that is really striking to me is how quickly you've been able to translate research findings into programs and into policy. And that is often where so many research programs really stumble and really are challenged. I know you all have a lot of experience, and I'll say that a significant amount of that success is due to having worked in this area and trying to do this before. But Turkana is relatively new to you. I wonder if you could reflect on what you think were the aspects of why you've been so successful in that translation.
Before I let Gilchrist or Diana answer that, I just want to say that Diana and some of our colleagues for CRS just 2 weeks ago sat and helped write the Kenyan guidelines for SMC. So another, I think, really important policy win for malaria control in the arid regions of Kenya.
I would say that there are many things, but one of them is the policymakers, they sit in Nairobi and they sit in their headquarters there at what we call Afya House, which means Health House in Nairobi. And we ever since we started working with Wendy more than 15 years ago, we never start any new research project before we contact the malaria control program and tell them what our ideas are and what we would like to do, get their buy-in, get their support. And they have done that for our research in Western Kenya. It's only when it came to Turkana where they dismissed us and told us that there's no malaria in Turkana. But once we have involved them right from the beginning and they know what it is that we're doing, then they're very supportive. And because they have seen the results of our work, because we ask for opportunities to present to their, what they call now, they used to be called TWGs, technical working groups. Now they are called COEs, centers of excellence. For example, there's a center of excellence on chemo prevention, on operations research. We sit on those committees and we share our work with them. As we are developing the work and as we get the results, we share with them. And they have seen for themselves that we do provide good data. They've seen for themselves that we do rigorous research, good methodologies, we work respectfully with the communities, and that our results have a lot of meaning that can be translated into policy. So that's one of the ways that we have managed to get this work, our work, translated into policy so quickly. In fact, these days they look for us. We almost don't have to look for them because they know that we do produce good results with this collaboration. Over.
Thank you.
Yeah.
Yes, Leah.
My name is Leah. Thank you so much for the presentation. I resonate with malaria so much, having coming from Kenya and even experiencing it as a young child. But I had a question. In the recent years, you've seen we have the malaria vaccine, and we see it may be covering one of the species. So I wanted to understand how the uptake is in Turkana County and if we have any positivity in terms of any improvement in malaria in terms of the vaccine, apart from now the vector-borne control, which we appreciate in terms of the work you're doing. Thank you.
Any other question? All right, we have other questions in the Q&A, and I'll probably just read these quickly from Gideon Johannes. Said, in the area, is the area conducive for malaria mosquito breeding? You mentioned the lake is saline, and there are mosquitoes which breed in the shores of the lake, which are adapting to saline. I think that's a question. If you have something you have as a country for this, I don't know. That's one question. You also mentioned the temperature is greater between 34 and 39. What do you think is conducive for this? Do you think this is conducive for malaria transmission? And also we have a question from Simon Kariuki. I'm going to just pick randomly because you're running out of time. Just wondering how you got funding to do this incredible piece of work despite skepticism from the malaria control program that there's no malaria in Turkana. Yes, we can probably randomly answer that. You can begin with the question on vaccine. Then the question on whether, we have breeding sites around the lake, and how are you able to identify some support to go about this work in Turkana? Over. And I'll probably start with Wendy.
A wide array of questions, but I'll try to hit a few of the high points. As far as funding goes, I think the fact that there was some controversy about whether there was malaria in Turkana actually strengthened our application for funding, because it was clearly an important area to explore. So, we were just persistent in pursuing funding, and we eventually received funding from the NIH to start the work that we initiated in 2017. The question about the vaccine, I guess I would just say that the vaccine is licensed for very young children, and it's only about 30% effective, and so it's 30% effective for a year. So it's really, I think, not a tool that will be very helpful in Turkana. Hopefully with iterations on the vaccine and more effective vaccines, that will become a reality for Turkana. Let's see, what was the other question? About the vectors? You're right. The person who wrote that question is right, that the vectors do not breed in the salty water, and even the borehole water is often salty or alkaline, and the vectors don't breed in it. So it's really the fresh water that's coming in through the seasonal rivers and from rainfall that create the breeding sites. But people and animals also don't prefer to drink the water, and so there's a lot of risk that's created around the way that people harvest and store and use water.
Thank you. We also have many other questions. I can't go through. Yeah, yes. 2 minutes? 5 minutes. Okay. So I can't go through everything, but I probably can pick one from Jean Mathieu. It says, do you think Plasmodium species anti-malarial drug resistant could also explain the recent increase in malaria incidence in Turkana? Yeah, over to you.
We did some profiling of anti-malaria resistance in 2017, and we didn't find any significant markers of like artemisinin or partner drug resistance. There are some moderate levels of resistance to some of the like SP, which we use for malaria and pregnancy, although they're not using that in Turkana until this last year. But I don't know. We need to do the studies for the more recent infection.
Thanks. All right. I think we have. Do I go for one more? Okay. All right. One more question. I'm bit keen on time. All right. And this is to Professor Diana. Is there any study to species versus breeding sites? Are there the three species of vectors, such as Arabiensis and Colusi and Stephenson, co-inhabitation in the same breeding site and or inhabiting the same breeding sites, and were they collected from different breeding sites? When we saw the different species, were they all found within same or in different spots? I think that is the question. Over to you, Professor Dana.
Well, some of them have got the same Oh, I'm having challenges with my devices now, so excuse me for that.
No problem.
Wendy, can you tell us about the past study? That's why I had to even switch from my computer to my phone, which is not working so well for me either.
Sure. So these mosquitoes, the mosquito work that we showed in this presentation were adults that we collected. We did do some larval work. I can't exactly remember the breakdown of the different species in the different larval sites, but we found anopheles in like the cisterns in the urban areas and in the irrigation canals and in the water panning sites all. But the Stevens eye that we found was in a water panning site that looked like it could have been a very nice Anopheles gambiae breeding site, right? So it's we didn't find Stevens eye in the places that they're finding them in Ethiopia, like in latrines and dirty tires and things like that, where you don't normally find, normal self-respecting Anopheles mosquitoes. But yeah, apart from that, I can't remember the breakdown of the larval work.
Right. Thank you. I think we can wrap this up. I wish to thank all of you for finding time to join this Think Global session. And I think key takeaways here is, collaboration in academia is possible. Working with community is possible, and they understand the problem better, and they're willing to provide solution. And 3, we should continue innovating, and problems just don't go away unless human beings continue being innovative. And so I wish to thank everyone, and Michael Penn, the panelists, and my side bench team here for doing a wonderful job in putting this together. And I also wish to invite the panelists to say one word so that we can wrap this up.
Sorry, it's just so noisy here. I apologize, but it's been great to have this hour to talk about the work that we've been doing together in Turkana. I look forward to having more of your questions in person.
Gilchrist, do you have anything?
Yeah. Malaria was actually an entry, in my view, to effects of climate change in arid areas like this one. And there are many other areas like visceral leishmaniasis, trachoma, etc. And all we need is what I call the scientific and academic community to come out of the classrooms, work hand in hand with us so that we can solve global problems. Thank you very much.
Thank you. Professor Diana Menya, if you're online, you feel free to give your final remarks.
Yes, I'd like to say that what we showed, that is the vastness of Turkana and the sparseness of the population, the challenging terrain that we have there, and the mobility of people. This might make it look, make some people think that it is too hard, it is too expensive, the people are too far away to reach. But from research, from data from our SMC evaluation research that showed that 97% of children were reached with at least one dose of SMC, and 71% of the target population, which was 38,000 children, received all 5 doses of SMC, shows that people can be reached. They're not hard, they can be reached, but that is if we go to them. So who better to go to these communities than community health promoters, who actually were the distributors of SMC, and they're part and parcel of the community. So our qualitative research showed that that people respected this kind of reception of health interventions. So why not invest in human resource? And if we invest in particular types of human resources there, then the vastness and the mobility, they all disappear. as reasons for not reaching people. People can be reached. Over.
Thank you very much. I wish to remind you all that this session has been recorded and it will be available on YouTube in the course of the week. And yes, we've come to the end of this. Thank you all.